Welcome to this series of lectures in oral medicine, this one entitled Oral Lumps and Bumps. The lecture will be given as a general overview of things that can cause lumps or bumps in the oral region. You will need to supplement this with previous lectures on such as those on bone disorders and salivary gland disease. To begin with, if we look at the various causes of lumps and bumps in the oral cavity, this can be from anything from normal anatomy to neoplasms. Just quickly, some of the normal or variations of the normal anatomy that can create alarm for clinicians could be the pterygoid hamulus, the parotid papillae, which if they're prominent can look like a swelling, the lingual papillae, and especially enlarged tonsils where you've got the enlarged lingual tonsil at the back, or enlarged foliate papillae on the lateral margin of the tongue, or even the circumvallate papillae, which occur in a arrow shape at the posterior border of the tongue. Erupting teeth can also may bulge out of the alveolar mucosa and may create some alarm to either patients and or the inexperienced clinician. In a developmental sense, we can look at hemangiomas, which is a vascular lesion usually occurring present at an early age or even at birth. These are due to structural deficiencies in the vasculature. In a similar manner, lymphangiomas, which is a lymphatic related developmental disorder, abnormality. Here, hemangioma, which is a benign proliferation of blood vessels, as mentioned earlier, found at an early age, whereas as age increases, people tend to get lingual varicosities, but these are again usually bilateral in nature and therefore clinically more apparent. Lymphangioma is a congenital malformation of lymphatic vessels, which may be as a result of misplaced lymph tissue during development. Management is either surgical removal, laser or sclerotherapy. And lymphangiomas will, with increased vasculature, as seen in this diagram, can be quite unsightly. Other developmental conditions such as the mandibulomaxillary tori, which is basically overgrowth of normal bone, and also the condition called hereditary gingival fibromatosis, which is associated with a gene located on chromosome 2 and 5, and it includes slow growth and progressive overgrowth of fibrous connective tissue component of the gingiva. And generally there, it's a symmetrical generalized enlargement, and if it's excessive, then surgical improvement may be required. Neurofibromatosis, or type 1, which is von Recklinghausen's disease of the skin, is an inherited disorder associated with chromosome 17, but can have new spontaneous mutations in up to 50% of the cases. In the oral cavity, you might get multiple intraoral neuromas, café au lait, which is the colour of the lesion, macules of the lips and face. So in von Recklinghausen's disease of the skin, you can have multiple neurofibromas, these café au lait pigmentations, leaf nodules, which is freckling within the iris of the eye, short stature, scoliosis, and seizures. Inflammatory causes of swellings in the mouth, most commonly an abscess, which is a pyogenic organisms causing pus-producing swelling of the tissues through inflammation and possible abscess formation. Here, even though this is an edentulous patient, there may be a retained root in that situation, causing this swelling and infection in the lip. Pyogenic granuloma is a benign inflammatory response to chronic irritation. It's inflamed fibrous epulis basically, and in this situation there's quite a lot of inflammation, and there will be a lot of vasculature in that lesion. Therefore you need to improve the inflammation before you look at the possibility of excision. Otherwise there will be a lot of bleeding. Crohn's disease, orofacial granulomatosis, sarcoidosis and Wegener's granulomatosis all can produce granulomatous lesions in the mouth, which, unlike tuberculosis, does not cause caseating granulomas, and further tests and or good history is required to make the diagnosis. Epulus, which is a swelling of the gingiva, can be apparent because of local irritants and or trauma, or a fibroepithelial polyp, which is an epulus in not on the gingiva, or denture-induced hyperplasia with ill-fitting denture causing overgrowth of the mucosal tissue. And again, in this situation, removal of the traumatic episode and or irritant, and then possibly excision of the epulus will lead to good resolution. Swellings can be arising from the bone, and these could be due to benign or malignant tumours of the bone. And in this slide we have the WHO classification of bone lesions, which is benign tumours, including ameloblastoma, which is probably the more common one that you need to be aware of, keratocystic odontogenic tumour, previously known as odontogenic keratocyst. Again, that is another entity that you need to be aware of, and these will probably be covered in a further lecture, but do some background reading especially on those. Odontomas, which is basically anomalies of dental hard tissue development, and other bone related lesions, which will also be covered later. As with any classification, there's also malignant tumours, which are the malignant varieties of the ameloblastomas, as well as primary intraosseous squamous cell carcinoma, which can be arising from other lesions as well. Apart from bone lesions, there's also cysts of the oral cavity, which, based on Mervyn Shear's classification, can be divided into odontogenic and non-odontogenic cysts, as well as pseudocysts. Odontogenic cysts can be developmental, especially dentigerous eruption, and gingival cysts, both of adults and infants, lateral periodontal or botryoid varieties of the lateral periodontal cysts. Inflammatory, indicating that there's inflammation as to how the cysts have arisen, and these can be periodontal or radiculous cysts, residual or paradental, residual cyst being one that's been left behind after extraction of the teeth. Neoplastic cystic ameloblastoma, calcifying odontogenic cysts, and neoplasia developing in a pre-existing cyst can also occur. Non-odontogenic cysts are nasopalatine duct cysts, globulomaxillary and nasolabial cysts, whereas pseudocysts are so-called simple or solitary bone cyst, aneurysmal bone cyst, or Staphney bone cavity, which is on a radiograph may look like a well-defined radiolucency below the infradental nerve canal, usually due to the presence of salivary gland tissue. So the classification of epithelial cysts, again, the WHO look at developmental cysts and inflammatory cysts, as mentioned before. And this is just another way of presenting that information. And the classification was based on clinical, radiological and histological examination according to the WHO classification in 1992, Kramer and Pinkborg in 92. Salivary gland tumours, again, there's going to be a lecture on salivary gland disease, but this is a WHO classification, again, with benign and malignant lesions. Benign lesions, the pleomorphic adenoma being the one that you need to be aware of more, and it's the more common or most common benign salivary gland tumour. In terms of carcinomas, the malignant varieties, the mucoepidermoid carcinoma and adenoid cystic carcinoma are two more common malignant tumours of salivary gland that you need to be aware of. And as with anything, there are non-epithelial tumours, malignant lymphomas often can occur, especially in conditions like Sjogren's syndrome. Secondary tumours which have arisen from elsewhere and metastasize, unclassified tumours. And then you have your tumour-like disorders, which will be again covered in salivary gland disease lecture. So, to show you some clinical presentations, a pleomorphic adenoma, even though this is ulcerated, is a benign lesion, can occur in the palatal, from the palatal salivary glands. Adenoid cystic carcinoma, compare that to a mucoepidermoid carcinoma occurring in the palate, and a simple fibroma, which is non-salivary gland, just for comparison. Fibroosseous lesions, Waldron classified these in 1993, and these include fibrous dysplasia, which is polyostotic, which means many, involving many bones, or monostotic, single bone. Reactive periodontal ligament origin are the periapical cementosseous dysplasia, focal cementosseous dysplasia, and florid cementosseous dysplasia. These more commonly occur in African Americans and usually appear as periapical radiolucencies on vital teeth, and no treatment is usually required. Fibroosseous neoplasms, the main one you need to be aware of is cementossified fibroma, and then Paget's disease of bone, which is a condition that can sometimes present clinically and cause clinical problems, especially with extractions. So fibrous dysplasia, what we see here is an expansion of the upper right maxillary segment, and here again this is Paget's disease, where you get excess bone growth. And in this radiograph, what you see here is a pattern of bone formation here, which is different to the adjacent normal bone. It's a bit more compact, and these are patterns that you need to be aware of. Hormonal causes of swellings in the mouth, again a pregnancy epulis, which is same as a pyogenic granuloma but occurring in a person that's pregnant. That can occur with the contraceptive pill as well. Antiepileptics such as Dilantin and phenytoin, or immunosuppressants such as cyclosporin and calcium channel blockers, can all cause generalized gingival enlargement, and this is histopathologically it will show a very similar pattern, but this enlargement is a fibrous component enlargement and can cause problems with oral hygiene, which will compound the problem of swelling through inflammation. incidentally, with the medication-related enlargement, just proper oral hygiene or increased levels of oral hygiene will help to maintain the health. Blood dyscrasias such as leukemia and especially acute myeloid can cause boggy swelling of the gingiva, which also spontaneously bleed, or lymphoma, which is a localized tumor of lymphoid tissue, especially non-Hodgkin's lymphoma, can also cause swelling in the mouth. So with regard to non-Hodgkin's lymphoma, it usually arises within the lymph nodes, grows as a solid mass from B lymphocyte series, usually occurring in adults. In the oral cavity, usually occurs as an extranodal lesion. And classification may be a high grade or intermediate or low grade. Low grade having a better prognosis, which you may just watch and review clinically. Treatment rituximab or monoclonal antibodies directed towards cluster differentiation 20, which is a B cell surface antigen. Hodgkin's disease, here what you have is malignant lymphoproliferative disorder showing Reed-Sternberg cells, which are under histopathology, looks like these owl eyes, double eye appearance of the cell, and make up only 1 to 3% of the cells. It's B lymphocyte again in origin, arises in the lymph nodes as a persistent enlarging mass, and more commonly in males. And it could be due to a nodular lymphocyte classification, or classical Hodgkin's, which is lymphocyte-rich nodular sclerosis, mixed cellularity, lymphocyte depletion, or unclassifiable. These are the different varieties that histopathologically that can be distinguished, but from a clinical point of view, we know that radiotherapy and chemotherapy is required for management. Burkitt's lymphoma are quite common it's endemic in East Africa and associated with Epstein-Barr virus, and it's predominantly an extranodal lesion. And histologically, you see a classical starry sky appearance, and it responds well to chemotherapy. Other neoplasms, benign neoplasms and malignant neoplasms, both can cause swelling in the mouth and ulceration. Here in this lower clinical photograph is a oral mucosal cell squamous carcinoma. Angioedema, which is basically an allergic hypersensitive reaction, can cause non-pitting subdermal edema, seen around easily discernible structures such as periorbital, lips, tongue, oropharynx and genitals. Can cause rapid pharyngeal obstruction as the swelling increases and cause difficulty with breathing and can be fatal. Unlike urticaria, there is typically no itching of the affected skin. In this lower photograph, you see we discussed amyloidosis causing enlargement of the tongue, where deposition of amyloid secondary to proliferation of abnormal clones of plasma cells often is a feature in multiple myeloma and leads to an enlarged tongue. Thank you.